Thank you, Ty. Our first speaker today is Dr. Sandeep Patel. He's an interventional cardiologist at St. Rita's Medical Center in Lima. He is also the director of the Percutaneous ECLS program at his institute. Dr. Patel, thank you.
Thanks, Carla. Thank you to Sandeep for putting this fantastic conference on. I'm going to share my screen here. Sorry about that. All right. So can we see the screen okay?
Yes, looks great.
All right, perfect. So like she said, like Carla said, my name is Sandeep Patel. I'm I'm the director of the Structural Heart Intervention ECLS program out here at St. Rita's in Lima. We're a community hospital, about 500 beds. And I was asked to give a talk on a very interesting topic that's come up in the recent years for interventional cardiology, which is left ventricular decompression during VA. And really you have two options. Is it optional or is it mandatory? So we're gonna go through this and try to explain to you guys the pathophysiology and what I mean by left ventricular distension and decompression. So just some objectives. We got background physiology of LV distension and decompression, risk factors, who do we need to vent, methods to vent. We're going to talk about two studies, both of which I was fortunate to be a part of, that kind of added to the literature on LV distension and decompression, and then future issues and directions. So obviously, everybody on this conference knows that acute VA ECMO insertion is for CV shock or arrest. And really what we're trying to gain there is to allow for cardiac arresting, to support the systemic circulation and to preserve the other organs' oxygenation. And then it also provides the team time to figure out the underlying cause. However, the entire premise of VA ECMO and all of what I just said is based on the idea that you want to restart or improve the left ventricular ejection fraction. So you have to stop any insults to injury, basically. So we're trying to avoid LV distension, intracardiac aortic thrombus, and then ultimately pulmonary hemorrhage from increase in pressures. So as you know, when we put VA ECMO percutaneously in the cath lab at the bedside and surgically, we get retrograde aortic flow, which acutely increases the amount of force that the LV, the left ventricle, has to pump against and jeopardizes the recovery. Actually, some reports and literature will suggest that up to 60%, more than half, will just demonstrate this degree of afterload mismatch. And so then we need to think about how do we prevent this mismatch and how do we relax the left ventricle? Because although we're supporting the other organs, we may not get the heart recovery we're looking for. So the physiology is twofold. So you have LV distension, which is blood filling the ventricle, but not emptying. So you need two things for that. You need a source for blood to enter the left ventricle. And then you need the fact that the LV is unable to eject blood, which implies that the aortic systolic pressure is higher than the left ventricular systolic pressure. And then when those two conditions are met, we have two conditions that occur. And those two conditions result in increased, what we call left ventricular end diastolic pressure. This is the pressure that's generated from the volume of blood in the left ventricle. And it causes left ventricular wall stress, which ultimately results in oxygen demand and continued subendocardial ischemia, which is the whole purpose of the ECMO, to prevent all this from happening. So who gets it? Well, it's obviously high afterload from the flow of the ECMO on inadequate pressor therapy. If you have complete cardiac arrest and no pulsatility, there's no way to drain the lung system. And so you get stagnation and dilation. If you have aortic valve insufficiency, the valve, you're injecting blood at a high rate, 5+ liters sometimes into the aorta, and the aortic valve isn't closing. And so now you're filling the ventricle through that unclosed aortic valve. Again, severe LV failure, if the flow rate on ECMO is very high and is basically generating a systolic blood pressure greater than the left ventricular systolic pressure. And then if you have a lot of volume to start with. So these guys are really the 6 things that you're looking for in the patient prior to entering a VA ECMO situation that's going to result in LV distension. And how do we manage it? Just medically, quickly. We're using inotropes, dobutamine, and milrinone, which are also vasodilators to help reduce the afterload. We're trying to keep mean arterial pressures in the 50s and 60s. And in ECMO flow rates, although we want higher flow rates to clear all the injury and all the acidosis, sometimes it's not always better. And we have to find this fine balance between lactate, pH, and venous saturations, along with the LV afterload, which is not typically looked at as a parameter that should be followed. How do we manage the venous drainage portion? Again, medically, we turn up the PEEP to kind of press out the blood out of the alveoli. We try to extubate as soon as possible, even if they're still on VA ECMO. We're using Swan-Ganz catheters, and then obviously dialysis and diuretics to get rid of the blood. And then if you have aortic valve insufficiency, we're trying to speed their heart rates up. Does the patient need surgical correction with a stitch? And then some people have even put in TAVRs for these patients to stop the valve from leaking so that the ECMO can work and get through the acute insult. Now, who should we vent? This is a very hot topic in interventional cardiology, and probably cardiac surgery and in perfusion in patients and people that are studying the physiology of LV dysfunction, because we don't have criteria. It took me 5 to 6 papers, and then talking to other experts about who are the number 1, 2, 3, 4, 5 patients that we should be thinking about venting. So it's a non-opening aortic valve, severe AI. So if you're not opening the valve or it's a stenotic valve, the LV can't eject the blood. So then you got that problem. If you have an open valve and the blood is filling too fast into the ventricle, you have that problem. If you do an echo and the LV is not moving, that's going to distend because you're not ejecting faster than you are filling. If you have severe pulmonary edema and you need to clear out those lungs so you can get off the oxygenation portion of the VA ECMO, that's another person we should think about venting. Hemorrhage suggests that the pressure is so high in the pulmonary arteries that you're actually back bleeding, and that those patients should be vented. And then if you're watching it dilate or the patient has refractory VT where they have bad rhythms in the ECMO circuit and the RV is not really doing what it needs to, you need to think about venting. So I know a lot of people don't look at pressure volume loops. So I'm going to try to orient you guys on this pressure volume loop. So if you look at the blue curve, basically my arrow, if you guys can see it, hopefully, starts at 50 there. And then it goes up this curve, which is the filling of the ventricle. And then the ventricle ejects up to a certain pressure. That's the red. Sorry, the ventricle fills, increases its pressure, and then opens the valve and ejects the blood, and then it relaxes. So there's a filling phase, there's an isovolumic contraction phase where we're increasing pressure, we're opening the valve, ejecting, and then we're relaxing. So when they go into cardiogenic shock, an acute cardiogenic shock, what happens is immediately you're filling, but you're not ejecting as much as you should be. So your stroke volume, which is really the area or the full, if you colored this this curve in, that's the amount of volume or stroke work that the heart is capable of doing. So you can notice that in normal cases, at low volumes of filling, you're able to eject a significant amount of blood and at a certain pressure. But once your heart starts to fill, you can't eject at those pressures anymore. And your stroke volume drops, which causes you to have a lower output and then ultimately organ failure. And chronic, what happens is, this is acute where we put the ECMOs in. In chronic, what happens is that your LV has time to figure it out. It's remodeled. And so it tries to maintain this same amount of volume ejected. And that's why you can have lower EFs with normal stroke volumes. But what happens when we put these ECMOs in these acute cardiogenic shock patients? So this is one of my favorite figures. So if you watch, this is a patient in cardiogenic shock. And at the top here is his baseline blood flow rate. And then this is an ECMO circuit started at 1, 2, 3, 4, and 4.75 liters per minute. And what you're watching here is the curves that are changing. And you're watching that at baseline, you have this great ejection of blood. And then as we increase the flow rate, what's happening is that the pressure, the afterload is rising. And as the afterload continues to rise, the heart stops ejecting blood because it just can't against that force of blood flow coming in from the ECMO circuit. So the curves get smaller and smaller and smaller until you get to 4.75 liters per minute. And again, this is the total amount of stroke volume ejected. It's nothing. It's not enough to sustain the cardiac output of the body. And you have a higher pressure, lower ejection of blood, which results in LV distension and stagnation. So, and we see that with the pressures over on this side. So you see that ECMO, although it does what it's supposed to do, the ventricle, what you're trying to save, is not happening. So how do we vent? So we vent in 3 different ways. We have medical, we have surgical, and we have percutaneous. So medical venting is sort of what we had already alluded to. Dobutamine and milrinone, aggressive diuresis, get rid of the fluid. Sometimes we get nitric oxide for RV support and turn on the ECMO flow rate. Those are the basic maneuvers that people do on a daily basis to prevent LV dilation, stagnation, and distension. And when we do that, so we look at this. So we see that this is the cardiogenic shock curve, and then we put the patient on ECMO, which is the red curve in panel B. And then if I put them on an inotrope, what happens is I can now squeeze better. So if I squeeze better, I can eject more blood and drain the LV more. So I start at a lower volume from filling. So that the green curve tells me that I had more stroke volume, which is a higher cardiac output compared to just the ECMO. If I do that with vasodilators, same thing. If I drop the afterload, this sick heart can keep the pressure low and pump more out if the blood pressure will tolerate it, obviously. So medical venting does work, but it's theoretical because over time, inotropes and vasodilators either affect the blood pressure, or as we always talk about in cardiogenic shock, you're beating a dead horse, you're making it work harder, and you outstrip the ability of the myocardium to continue doing that for a long period of time. Thus, surgical venting came. So surgical venting has been done for years by surgeons who've been placing patients on ECMO, and they do it basically through direct LV venting or indirect LV venting, which is they put a cannula into the left ventricle or into something that drains into the left ventricle, which is the left atrium, left atrial appendage, the PA, or they put it through a pre-existing sternotomy, whatever it takes. But basically, you are putting a cannula surgically into the patient and then connecting it with a Y connector into the venous limb so that you can keep the LV drained and keep the volume in the ventricle low so that it doesn't have to fight and try to eject such a high pressure. And there's a study done around 50 patients years ago that showed if you vented patients, they had a higher 30-day survival with a smaller LV size. Now, these are small studies, and as you'll note throughout the entire talk, ECMO studies are not large studies because you need a lot of patients, and randomizing these patients becomes an ethical issue of who should get what and what we should do. So we have the best data we have are sometimes on anywhere between 20 to 100 patients total, until recently when we had a 600 patient study done. So other surgical techniques are minimally invasive surgical stents. They use anterior lateral mini thoracotomies, and basically same thing. They put a cannula into the left ventricle, and this study in 2017, only 20 patients or so, but it showed that the pressures came down and the mixed venous saturations came up so that they improved their overall outcome. Now, these patients also had a secondary afterload reducing mechanism, which is a balloon pump. So we can't really say that it's directly from the vent, but it's a combination of unloading of the left ventricle. So that's a picture of a LV vent directly into the left atrium through a sternotomy. You can see that it's sucking directly out of the left atrium. And this blood will go into the venous limb of an ECMO circuit and keep the blood from entering the left ventricle. So when you do an LV vent, what does it look like? So again, the blue curve is your cardiogenic shock. If I put the patient on ECMO, that's the red curve. And then if I add an LV vent, you can see, again, the stroke work increases, the pressure decreases, and the amount of blood you're starting with from the ECMO circuit to the LV vent at ECMO circuit is lower. So all 3 things have decreased afterload, have decreased preload, and have increased ejection of blood, resulting in better cardiac output in the long run. Then came percutaneous techniques, because obviously we can't run everybody back to an OR, or there's not enough time, or we need to get something that's less invasive for all the surgical issues that will arise from putting vents in patients. So there catheter-based approaches. So we can do a transaortic vent where we can just take a catheter up the groin, or for that matter, sometimes even in the radial artery, and put it across the aortic valve, put it in the ventricle and suck it and basically draw off it and put it connected to the venous line. And now blood is drained from the left ventricle directly into the venous circuit through a small catheter. That's a rapid insertion technique, but it doesn't do what you need it to do because it doesn't drain the volume as quickly, but it is something that's optional. Then there's a transseptal vent where basically we take a venous axis from the femoral vein, go up to the right atrium. And now, as most of your centers do, mitral clip and Watchman and TMVRs, a lot of interventionalists and cardiac surgeons are becoming more adept at crossing the intra-atrial septum. So we cross the intra-atrial septum, place a cannula directly in the left atrium and suck the blood directly out of the left atrium before it enters the ventricle, hook that up to the venous limb, and then you basically are perfusing through this circuit. However, again, percutaneous techniques in this realm require a puncture. You're doing it under a very critical scenario of cardiogenic shock. And the cannulas sometimes don't stay patent. And sometimes, again, we're putting small enough holes that don't drain the blood significantly. Or the opposite, we put very large cannulas across the septum, and now we have to do a transseptal ASD closure to prevent the left to right shunting. And then there are people that don't even leave a cannula and they just do something called an atrial septostomy, which is where we cross the septum, put a big balloon there, tear the septum, and allow blood to shunt left to right. And then you have a venous limb. So you allow blood to shunt from the left atrium to the right atrium, and the venous limb is sucking blood from the right atrium directly and putting it into the circuit. So that can be done as well. And then there's transpulmonary venting as well that's done from right IJ to PA. Similar to a Protect Duo device that people place. So it's, again, sucking from the PA directly into the venous limb. But again, all these things haven't had randomized controlled trials. They're really just observational studies to say this is a way to vent a patient percutaneously. Is it similar to surgical venting? Unknown. But let's look at what happens to the patient. So if you have the red curve being your Ecmo and cardiogenic shock patient, and you added an ASD, which is basically a balloon atrial septostomy, where you made a hole between the left and right atrium, you can see that the pressure drops immediately, the afterload drops, the volume drops, but this is the ventricle still in pain, and you're not getting the stroke volume you want. Okay, so the work, although it's less, you're not getting the cardiac output you want, because now you're basically stealing from the left circuit and not truly putting it back into the left circuit. You're putting it back into the right atrium, into the right circuit. This similar thing happens with the LA vents as well, where if you just have a cannula there and you're stealing the blood directly from the ventricle, yes, you've decompressed and you've unloaded, but you're not helping the ventricle get the cardiac output that you need. Then came ventricular assist devices. So what's the purpose of a vent? A vent is to reduce the afterload. Well, the simplest afterload reducing device we have today is intra-aortic balloon pumps. And they've been on for years. And so you can put the balloon pump in, you'll increase the diastolic pressure of the aorta, which improves coronary perfusion, and you reduce the LV afterload. However, this comes with its own problems, right? So the VA Ecmo cannula, the A portion is coming up the same portion that the intra-aortic balloon pump is coming up, and you're disrupting flow 60% of the time when they're in diastole. And that reduces the aortic root pressure when that happens. And so when the aortic root pressure reduces, you may actually cause stagnation, but you're not, because you don't know how much it's reducing it by. However, that being said, when you do it, your pulmonary pressure or your wedge pressure drops about 4 millimeters of mercury, which is not totally substantial, but if you go from 34 to 30, not the biggest deal, but if you're going from like 20 to 16, that may make a reasonable deal in the patient's overall outcome. And the other problem is that, as any other study that you can see, since IBP has been around so long, observational evaluations can be done, and they have a huge study with 1,500 patients showing that there's no benefit. And IBP, unfortunately, has never shown clear benefit for these types of patients, let alone acute myocardial infarction patients. But when they keep looking and looking and looking, they do see that if you combine an Ecmo circuit with a balloon pump, you may do better without having a lot of other risks going on. But you still really don't know the overall benefit because it's not randomized. And they've done systematic reviews again, using some of these data are the same patients being looked at in different forms. But the other thought was that allows the Ecmo to come off easier because you have something else bridging the afterload reduction for the patient's LV. So that was pretty historical, but still done in contemporary practice with patients that have mild or minimal LV distension. And when you do that, you get this reasonable curve where you have the cardiogenic shock curve, which with the Ecmo in the red, and you get this reasonable curve where you have good stroke volume with a lower pressure. However, in the end, is it sufficient for your cardiogenic shock patient or not? We really don't know. Again, this is a schematic, so everybody's cardiogenic shock patient is at a different spectrum. And then you still need to think about what are the issues with vascular access. Can you get it up there? Is the patient in atrial fibrillation? Is the timing appropriate for the balloon pump? And all these things kind of play into, is it really going to make sense to do for your patient? Or do you think you need more afterload reduction, et cetera? So there is the Tandem Heart, which can function as an afterload reduction in the setting of a VA ECMO, which is a lot, but people have done it and discussed this by placing the cannulas directly into the LAFPA and aspirating. They kind of call it a lava circuit where there's an LAVA circuit. And it does do what it's supposed to do, basically, is to decompress the heart and decompress the LV and provide the VA support. But then came what we all know in interventional cardiology is the Impeller device. So for those of you who are not accustomed, but I doubt that at this point that you're not accustomed to the Impeller device, but given that you're all perfusionists at putting in VA ECMO, but just to kind of give you the background. So this is a retrograde transaortic microaxial flow pump that basically has an Archimedes screw type propeller placed into the ventricle underneath the aortic valve and sucking from a pigtail portion due to the propeller, due to the turning of the propeller at certain speeds, sucking blood directly out of the ventricle and then injecting it above the aortic valve around the arch. Okay, and when patients have had VA ECMO and placed in an Impeller at the same time, they saw immediate decreases in the diastolic diameters of the ventricle, and the pulmonary edema improves. And it appears to be additive in terms of flow augmentation, although that remains to be completely understood. And additionally, it prevents root stasis because it keeps the blood moving above the aortic valve despite the ventricle not ejecting. And because it can be put in a cath lab, OR, femorally, axially, subclavian, and there's so many ways, transcavally, there's so many ways to put it in. It's almost become a fully percutaneous and the readily available option in settings of needing LV decompression or LV support. So this is a quick picture. I want just to orient you guys. This is a TE image. Here's the left atrium at the top. Here's the mitral valve. Here's the left ventricle. Here's where the aortic valve would be. You should see a single line here, but what you do not see is a single line. You see a filled up aortic root here. And this is thrombus in the aortic root of a patient on ECMO. Okay, there's no, this blue is the color. There's no color flow out of the valve. So it is a real thing with stagnation of blood flow. And if you prevent this, because this is the next thing that's going to happen is the patient will start ejecting blood. And unless you have removed that thrombus or anticoagulated it and watched it dissolve, once the valve starts moving, if it can move at all, it's going to eject it straight up into the cerebral circulation. And this is where stroke starts happening. So Impeller is used for both sides. It's on the left side and the right side. The left-sided Impeller is on the left side of your screen. You can see that the Impeller motor that sucks from here and ejects it out above the aortic valve. This is the aortic valve here. And then they also make it for the right side if you really needed it, where it basically draws blood from the IVC and injects it above the pulmonic valve into the pulmonary circuit to allow for oxygenation. So does it work, or this combination of ECMO plus Impeller, which we dub Ecpella? And there have been two really good studies looking at this, the Tepper study and the Pappalardo study. Basically, the first one was the Ecpella versus ECMO in a surgical element. They didn't find any difference in survival, but they did have a reduced PA pressures and pulmonary edema. Now, they're not going to find a difference in survival, which this has been discussed, is that, well, they're both venting. So we're not going to see a real difference. We're not comparing what we really want to know, which is, does Impeller venting versus just ECMO provide you what you want in terms of a surgical vent? And the Pappalardo study was a fantastically done study, all in Europe, multiple centers, and really showed you had lower hospital mortality and you had a higher bridge to recovery or bridge to some further support in the Ecpella group. So when that study came out, I was still training years ago, about 4 or 5 years ago, and we were looking into this at my prior institution at University Hospitals in Case Western in Cleveland. And that kind of gave us the onus for doing our study. So just so you have an understanding, here's your ECMO circuit, same thing. We have a patient with cardiac shock. We add Impeller, the stroke volume increases. And now you added Ecpella. And what's happening here, which is somewhat counterintuitive, is that the curve has heightened. So it's gotten higher because you're increasing that pressure, but you're basically decreasing the work of the ventricle, but you're letting the body think that you have this ejection occurring. So you're resting the heart, but giving the ejection of what you would get if the heart was working, or at least at a higher level than what it is at that point. It's a similar curve, basically. You're coming down and you're increasing the stroke rate. So when you put that in, as when you look at a patient who's in shock, and then all of a sudden you put them on ECMO, the pulmonary capillary wedge pressure goes up, which is the surrogate for pulmonary edema. And it goes up because the afterflow has gone up and the LV is now not able to eject against this increase in flow. But the minute you start to decompress, where the Impeller now is sucking blood out of the left ventricle and then ejecting into the atrium, you start seeing the pressure come down. And this is a good sign. This is a sign that you're clearing the pulmonary edema and you're reducing the volume in the ventricle and you're allowing the ventricle to recover. Meanwhile, the body is getting the flow it needs from the ventricle, keeping the root clear, so you don't have any thrombosis above the aortic valve. So that led to our study. So there were at the time I devised the study, there was no US-based study or data on someone who had done simultaneous VA ECMO and percutaneous left ventricular decompression with Impeller. So we came up with this study, and again, it's single center. We looked over 2 years, and what we noted was the following things that were very positive about the study. When we did cardiac shock management, we used a very strict definition of cardiac shock. And every patient had a small advanced catheter, had all the lactates and the pHs and the cardiac indexes and the blood pressures. All the stuff was recorded very clearly because we were running basically an Impeller study simultaneously. And so the data was very clearly available. So it was a very homogeneous definition of cardiac shock done by a shock team that was established prior to 2014 that had become quite seasoned. And we had a very clear algorithm, inotrope, pressors, initiation of your VA ECMO, Impeller device insertion, that was followed by the shock team. And in a majority of cases, when we believe the patient needed VA ECMO, we went forward and put the Impeller in at the time, within 24 hours, which you'll see is even later than what you expect. But at the time we were doing the study, this was not really in vogue yet, although it was being discussed. And really that Pappalardo study was one of those seminal studies in LV decompression that we see that said, this makes sense to do and can be readily done. So when we were looking at outcomes, obviously we wanted to know a 30-day and all-cause mortality at 1 year. But we also looked at the other things, the ECMO support, the time on ECMO, inotropic score, need for dialysis, stroke, hemolysis, bleeding events. For those of you who are not familiar, the SAVE score, survival after VA ECMO, a lot of risk factors of the patient, put them in, and then we get a score that predicts their survival. The inotropic score is similar because people use different doses of drugs for different lengths of time. The inotropic score takes all those variables into consideration, and then produces a uniform numerical score to compare different patients on different levels and amounts of inotropes. So this is a way to standardize the evaluation of those patients. When we look at it, the VA ECMO and the Impeller cohort really had no major differences in the two. They were pretty standard patients that were seen. And again, small cohorts, but still relatively within what ECMO studies are done, which is anywhere between 20 and 100 patients, unless they're doing a composite analysis. So looking at things, this is a basic study, a basic baseline of characteristics for VA ECMO and ECMO patients. I'm sure you see it at every hospital you work at that show very sick patients. And when we looked at the primary outcomes, if you had VA ECMO or Impeller, so if we just looked at the 30-day outcome of a VA ECMO patient, the mortality rate is 68%, which is pretty much in keeping with cardiogenic shock at the time we were doing the study. But when we looked at the Impeller cohort, the ratio had dropped to around 57%. And that was significant. And it stayed significant for quite some time. We looked at it out to 1 year, and the overall mortality, 80% had died, 20% had lived, which is, again, similar to other ECMO studies. But you looked at the Impeller cohort, and it was lower, statistically significantly lower. And if you had STEMI, it was even lower, probably because you added revascularization. So here are the curves. I mean, the curves split very early on, like very, very early on. Within days of the hospitalization, if you had decompression, you were going to do better. I mean, this is for control. We tried to control for every variable we could, and there's not enough volume of patients to propensity score match them in this study. But again, their baseline characteristics were fairly similar, and they were done by the same heart team, with the same shock team approach, with the same algorithm approach, with the same drugs, with the same, and then we facilitated the SAVE and inotropic scores to try to equilibrate the patient groups. And again, very early. And then if you lived, you continued to live. So if you made it through the hospitalization, you made it through the Impeller, you got through it, your mortality didn't drop at 1 year. And how did you die? So if you were going to die, you were pretty much going to die of what we always die of, multi-organ system failure in the setting of a very profound cardiogenic shock. And then the basic other things of CNS bleed or CNS dysfunction, stroke, and bleeding were there. Interestingly enough, you bled more in VA ECMO than Impeller. Whether that was because you facilitated taking the ECMO out earlier, unknown. We could not really figure that out because the number of patients with the incident was so low. Secondary outcomes were fairly similar, except for what we noticed was a trend in hemolysis over time with the Impeller group, or the Impeller group, but otherwise, really no major difference in hemolysis, major minor bleeding, creatinine, dialysis, discharge, stroke, or TIA. And when we look at support and weaning, this sort of is a very interesting story, right? So we put the Impeller in on these VA ECMO patients, and you look at day one, and this is the inotropic score. The inotropic score is fairly similar. So the amount of inotropes being used is similar on day one. On day two, the Impeller is doing its job, and you're dropping your needed inotropes immediately, which those in itself are causing a mortality increase. And then by day three, you're very low on inotropes and pressors, and you're really just relying on the Impeller. So it does get rid of one of those things that we know increases mortality and cardiogenic shock if we're using them for a prolonged period of time, not to mention the other systemic pharmacologic effects of the drugs themselves. And when we got to the point where we were going to decannulate, what happened? So in the VA ECMO cohort, you could see about more than half required something else. So we get to decannulation, now we got to put something else in. IVP, temporary IVAD, add more inotropes. Really, 13% required no support, while a majority required something to be done after we were ready to decannulate. Impeller was a different story. So 20%, 1 out of 5, needed another form of support, while more than half were maintained just on Impeller and inotropes. And then 10% were just on inotropes alone. So this is a very interesting trend. Now, is this typical? Unknown, but it is something we saw, and it was very clearly associated with the Impeller. And obviously, we're always talking about what's going to happen after the ECMO, and are they going to get to recovery? Again, the number of patients in the study were low, but numerically, it was almost double. And if you were in the Impeller cohort, you were more likely to recover. But again, this is not statistically significant. This is just numerically, again, because the volume, the number of patients was low. And then if you were going from Impeller or ECMO, did you get to VAD? Again, much more prevalent in the Impeller group as compared to the VA ECMO group, suggesting that there is a way, and hopefully a way, to recovery or bridge to VAD with Impeller. And hemodynamics, well, no Impeller study can ever use hemodynamics as of to date and to show a survival benefit. And we didn't really see a difference in the hemodynamic parameters between Impeller and VA ECMO, which kind of shoots the whole hypothesis in the wrong direction. Well, the whole point is to decompress and improve the flow out of the ventricle, and now we're not showing that the hemodynamics were better. However, what we did note was the cardiac index. So when we looked at the cardiac index, which is what is being ejected with the combination of the Impeller plus its native ejection and pulsatility, you can see that the blue line being the VA ECMO alone is really stagnant. But the Impeller group really surpasses by day 3, surpasses after decannulation to provide continuous flow out of the ventricle. And so probably the sensitivity and the fidelity of catheters and the measurements are taken at different times for all these patients. That's probably why we didn't see that that difference, as Impeller has been shown to show that improvement in hemodynamics. Again, does not translate to a survival benefit, but does translate to a hemodynamic benefit. But again, in our study, we couldn't show it. And again, I attribute that to really us not likely recording things at the right time, in the right patients, and the fidelity of the catheters and the measurements that we were making at the time. So again, because of that, you have a limitation of the study. It's single center, it's small, it's retrospective, and you can't always globally apply it. But our study, interestingly enough, did get a lot of press at the time, and was then mimicked by other centers at other large institutions. But we did get the attention of the Europeans, who had done that great study with Papalardo and a lot of the ECMO centers. And so we were invited at that time, in the last a year and a half, I was invited to be a part of a global international cohort studying the same parameter, which is left ventricular unloading in VA ECMO patients. And this is an international study. Now, this study is extremely long and very complex, so I'm going to try to put it into a nugget that makes sense to everybody. But basically, this is 686 patients between a long time, over a decade of time, who all had cardiogenic shock and VA ECMO between 16 tertiary care centers and 4 countries. Everybody put their patients in, and then we actually had enough volume to do a propensity score matching with and without unloading with just the Impeller device. So the vent is the Impeller. And this time, they also studied the timing of insertion. Remember, my study was done within 24 hours. Now we're looking at timing down to 2 hours. So less than 2 hours or greater than 2 hours. Because like we had seen, like other people had seen, those that were vented and vented early seem to have done better. But could we get some data to at least show some statistical difference? So the primary endpoint was, again, 30-day all-cause mortality. And the secondary endpoints was what we had already looked at, CVA, bleeding, etc. So we'll get to the answer here. So in the matched cohort, which is these patients, all the patients were entered, and then we used statistical propensity matching to try to keep all the patients as equal as possible in their baseline characteristics. And when we matched them, We had about 255 patients in each group. And if you matched them out to 30 days, and the Impeller cohort, the blue line, lived longer. The probability of death was lower at 30 days if you had an Impeller. Now, this is the first time that this volume of patients has been matched across multiple centers using multiple shock teams with multiple different protocols, inotropic management, etc. But if we just took the nuts and bolts of the data, put it in and did it, using all this heterogeneous data, we're still able to get a reasonable improvement in survival. That I would say the most impressive portion of the study was the unmatched portion. So this, if you just took all comers and just split the group, Ecmo and Impeller, split the group right down the middle, and said, did they live if we didn't even control for any of their risk factors? So everybody's different now. We're not looking at any risk factors, we're not matching patients one-to-one, nothing. Even they had a p-value of 0.05. So not statistically significant because it's not less, but boy, did it get pretty close to actually showing that difference is there in all comers despite not matching, which is very impressive when you're talking about a study under 1,000 patients. When we look at the cohorts and their complications, the complications are what you'd expect. So you're adding another large bore femoral arterial access. So you're going to bleed more. You may have ischemia related to the leg more, and you're likely to have renal replacement issues because of hemolysis and pigment-induced nephropathy. Also, again, a lot of these patients were added in early on, so there is a little bit of a selection bias in that, well, they're really sick. So the doctors seeing them are going to say, we're going to put an Ecmo in and we're going to put an Impeller into at the same time because they're just sick. So there is some selection bias there. But again, whether you took them unmatched or matched, if you took the selection bias out of the picture with the matched cohort, you still had a difference that was statistically favoring Impeller placement at the time of VA. So now let's look at the timing, because that's always a key. When should we put it in? At what point do we, bite the bullet and say we got to do it? So that in this study, they cut it down to 2 hours. 2 hours is the cutoff. Less than 2 hours, that's putting it in right away. Greater than 2 hours, it's not. So if you did early LV and loading, that's panel A, you could see the benefit immediately. P-value of 0.03, and the curves will continue to splay. And the benefits there out to 30 days. If you did delayed, hedged in hard and didn't really make a decision because you weren't sure, or you may not buy into the distension, or you think that inotropes, etc., may help you get through it. But the delay cost you, because although they may survive and the curves kind of splay out at 15, 20 days, the curves come right back to normal. And they will ultimately intersect so that the p-value never made statistical significance. So the timing did matter. So after all that, we get to the point of answer the question, is it optional or mandatory? So remember, LV distension is unpredictable, highly likely, approximately 60% of patients. And Impeller insertion by heart teams and shock teams has become the norm. And nowadays, remember, the study looked at patients 2005 to 2019, sorry. So the evolution of limb preservation, limb salvage, avoiding limb ischemia has become exponentially more well-seasoned in most shock teams in putting antegrade perfusion limbs, figuring out ways to do external femfems, etc., such that these limb ischemia things have also decreased in their total amount. Again, the study that we looked at was in the beginning of patients being used in VA Ecmo, and we were showing a difference. But these limb ischemia issues have been brought to the forefront in the recent years, so the techniques have changed. And that we know that if we use less inotropes, that the Impeller is going to allow for Ecmo weaning and a higher probability of survival. But again, statistically, hard to say with just one study showing this. And then maybe if we put it in early, we have improved survival. Again, the 2 hour window. So from my standpoint, is it optional or mandatory? Well, you're already throwing the kitchen sink at some of these patients. you might as well throw in the pipes, the faucet, and the drain. And it's the drain, the LV drain, that's the important part of this. That although you're allowing perfusion and oxygenation to the organs, you need to rest this left ventricle to allow recovery or bridge to some other therapy. So what are the issues requiring future studies? So obviously cost effectiveness becomes a huge thing here. We're putting in very large devices requiring double types of nursing staff, multiple technologies are being used simultaneously. So the cost effectiveness is actually being evaluated. Who should get this? Again, we talked about some patient selection criteria for LV venting. I did not say to you LV venting with Impeller should be done on certain patients. Again, these are very hard things to kind of conclude, and it's a hard local team decision. However, this study that we did with circulation shows that despite heterogeneity, it still helps. And then which type of decompression? Obviously, as an interventionalist and someone doing cardiogenic shock management, I'm in favor of the Impeller because it tends to go in sooner, it tends to go in quicker. Size of the Impeller, which size, we have different sizes of Impeller now that can be done with higher flow rates. But again, is that higher flow rate better? How do you match the Impeller ECMO flow rates so that you're optimally helping the ECMO and the ECMO is optimally helping the Impeller? You're not beating both. And then you're monitoring for decompression. There is no guideline on how to monitor for decompression at this point. Are you using pressures? Are you using LV diameters? Are you checking periodic echoes? What's telling you that you're effectively unloading the LV? And then bleeding and hemolysis, obviously. So conclusions here for their talk here. So LV dilation in the setting of VA ECMO is a real phenomenon based on experimental and real life observations. Impeller is a viable option with a good, non-randomized, but good clinical outcomes to support the use of this as a strategy to treat this problem. And in 2021, with the degree of medical advancement and the maturation of the heart team, the shock team, I don't believe it's optional anymore to avoid LV decompression therapies and wait longer, especially when you're seeing LV dilation, and thus should be considered at the forefront when insertion of a VA ECMO is going to occur. Thank you. I'll take any questions.
Dr. Patel, that was an amazing study that you did. Thank you for sharing it with us. We're now going to go open up for our panel discussion.
Hey, Carla, I'll start it off if you don't mind. Hey, thank you very much, Dr. Patel. Great studies and a very interesting talk this afternoon. We have several questions on this. I think you talked a little bit about it, but there's still a lot of questions on it with our panel. Which Impeller catheter was used the most? And was there a goal output for the Impeller to show better patient support? This from from Paul Shuttleworth.
Okay, so the Impeller catheter mainly uses 3.5 at the time of the study. It was 2018. Remember, we didn't even have the 4-liter augmentation of the percutaneous device. It was femorally placed in the cath lab. And the second part of the question was augmentation. So we, at the time, maintained max flow rates. We really didn't know better, and we're still not sure. So we kept them on max auto P9 to P8 flow rates the entire time they had the VA ECMO in.
Okay.
So Dr. Patel, it's funny when you're doing these virtual meetings and the panelists are all checking out the questions and trying to keep up with all the questions that are happening so we can condense them to ask you. And then you end up answering a lot of those questions during the rest of your lecture. So we have to move on. It's very, very kind of exhausting to do. But one of the questions that came up that you may have covered a bit is, when do you make that decision to actually go ahead and you're on VA ECMO, FEM, say, when do you actually make that decision, you personally, to put that Impeller or that Impeller in at that point? Is it an LV distension? Is there more than indicators, or when do you pull the trigger?
Yeah. So again, the basic criteria for LV venting, like we discussed, if I already know that going in, right? So if the aortic valve is insufficient, if they have aortic stenosis, if I have pulmonary hemorrhage, the pulmonary edema is profound, the oxygenation status is dropping, then And a lot of times they're going to get the vent up front. Okay. It's unfortunate in the world of cardiac shock, ask for forgiveness. Don't ask for permission right now, because you need to do everything possible, and time is of the essence for these patients. So for me, I'm fairly aggressive. If I'm going to do it, I'm just going to do it up in the get-go, because I'm already in the lab, I'm already doing it, and I need to get the perfusion limbs in, etc. But to answer your full question, you need to do the reassessment within 6 hours. And if the wedge pressure is rising, if the LV end diastolic diameter is enlarging on echo, and it is correlating with your flow rates, where your increase in Ecmo flow rate is causing these things to occur, there's no time to wait. And that should be done within 6 hours. Optimally, by the study that I just presented, was 2 hours. And I'm adopting that practice now, because it showed that curve split. And that's the only data I have to date to show some degree of timing, like a real bipartisan, some degree of timing that changes the management of the patient and the outcome of the patient. So early unloading seems to be better. A lot of the acute MI and shock trials are showing the same exact findings. Unload the ventricle first, and then go ahead and do your therapies that you want to do. So similarly, I think cardiac shock follows the same path. Unload as quickly as possible. And some people are making a decision to say that ECMO will always, like I showed that graph where as you increase the flow, the stroke volume dropped. Some people, experts, are saying it's always going to cause it. It's always going to cause some degree of increase in LV afterload that the ventricle that is in shock is not going to be able to handle, and just put it in up front. So there are two schools of thought. Again, cost-effective analysis, the complications, limb ischemia that are all associated with putting in large bore arterial access devices have to be weighed against the fact that you have a patient on the table with cardiogenic shock, and what's the best option here at this point. But
one thing you mentioned is that you're always looking at the LV, but isn't it true if you have some LV failure, your RV is the one that's most susceptible with the backup of the system. So you may have biventricular failure, and that might be why early intervention might be more successful.
No question that draining the pulmonary circuit with an LV Impeller will hopefully help you improve the RV. Now, the other option is to just bypass the RV, right? So we can put in a right-sided Impeller, put a bypass. So that you're getting very complex now. Are you going to put a bipel with a VA ECMO circuit because you need a biventricular failure? Or does biventricular failure, does that resolve with just the fact that you're putting a VA ECMO, and then you're just treating the decompression? So to be clear, the ECMO is placed because of the cardiogenic shock. The Impeller is being placed as an adjunct to prevent LV failure and continued LV insult.
Thank you.
Dr. Patel, Matthew Hillier would like to know that since implementing the use of LV vent in your ECMO, has there been a change in the occurrence of LV thrombus?
I can't answer that because I don't know. That we don't have that much volume to say that. The institution I came from, we did not see a lot of LV thrombus, although probably there is some. You'd have to MRI every patient to see all the thrombus that actually exists in the apex of the LV. But I would say, if you just ask me globally, no. If you ask me, is that truly an answer? Hard to say. I can say I don't see any global large globular thrombi in the left ventricle, and it should theoretically prevent stagnation of blood in the LV apex by putting the Impeller in there.
By using this intervention, have you seen any change in basically your ventilation and extubation times?
It's a great question. I think anecdotally we have. Okay, when we were doing the study at UH, anecdotally we have seen that they are more likely to extubate, but I don't have data on this. Again, this would be something you'd have to just physically study about extubation times. I can tell you that the pulmonary edema is less, the PEEPs go down quicker, the tidal volumes are better, plateau pressures are better, but is it really related to the VA ECMO, a healing heart, the inotropic therapy that's going on, the diuretics, the CVVH. It's just too many confounding factors to say the Impeller is definitively doing it. Again, hemodynamically, it should. All the data suggests it should, but can I say it's related to the Impeller or not? I can't.
What PEEP would you recommend if you have a patient that's in cardiac failure and you've used ECMO and Impeller? Would you maintain a PEEP of say 10 or so?
I think 10 would be probably too low. You really need to push those alveoli, keep them open and get them drained. I'm somewhere usually anywhere between 12, 15, sometimes even 16, pushing to keep the airway, to keep those alveoli open and drain them.
Then that's in the immediate period or throughout?
Yeah, pretty much immediate, because they're usually in fulminant pulmonary edema.
Yeah,
out lungs. So we need to get all the oxygen we can down in there. But the number, I can't give you a number. 14 if you have to pick one. I always say 14.
Yeah. Well, we always talk about lung protective strategies with VV ECMO, but this is a different game.
This is a different game. Yeah, this is a different game.
Yeah.
Brian D wants to know, if you do see early signs of hemolysis, do you come down on your Impeller flows, or do you always maintain those higher flows? Yeah,
that's a great question. That is a fantastic question. So hemolysis is typically two things in the Impeller. First, it's the position. Where is the Impeller? Did it move? Did the motor get close to the aortic valve? Something, you need to first check that, because if it's just a repositioning thing, great. Now, if it's truly just, it's chewing it up as quickly as possible, then yes, I will drop my flows to avoid that at all costs, because pigment nephropathy and the Coca-Cola urine that you start seeing tends of, I think, a pretty poor prognosis, because you're going to end up in dialysis for 3 different reasons: acute insult, continued insult, and now you're adding insult to injury with hemoglobin being chewed up and being shoved through the tubules of the kidneys. So I would say, yes, drop it. But first, check your position. Position is key, because if the position is off, I have resolved hemolysis many, many times by just changing the position near where the aortic valve is.
In fact, that's one of the questions about some people have more problems with position than others. Do you have any recommendations?
Yeah, that's a great question. How do you hold the Impeller in place when you're moving them? There are a couple things that people do and this is stylistic. I cannot tell you this is in a textbook at all, but stylistically. So first thing I do is, obviously, I always put the antegrade perfusion sheets in. That's like a bar none for everybody that gets a large bore access that I'm going to leave in, because pressors on top of a large bore axis are going to cause ischemia around the sheath at some point in the clinical course. You don't want to be running back to get an antegrade perfusion. That's part one. So why I'm saying that, to do that up front, so you're not manipulating the Impeller, getting it out of the way, trying to get an antegrade perfusion sheath in. Part two, the orange peel away sheath. The orange peel away sheath, it is made to peel away. I have found, and this is completely anecdotal, I believe Impeller doesn't reinforce this at all, so this is on me. I leave it in. I actually don't peel that sheath away and put the repositioning sheath into the patient, because as we're doing that, that usually moves the Impeller. Now you can check it on fluoro, but for some reason it's just not always perfect, and you're more likely to not touch the Impeller or reposition it after the repositioning sheath is in, because you don't want to start causing bleeds around where you just went in. So I tend not to do anything there. The third thing I do is, as most you probably do for your VA ECMO circuits, you got to have a limb binder or something holding the pump to the patient's thigh. And I suture that pump in 3 different spots outside of the sheath, then in the middle of the Impeller, and then a little bit more proximal to the motor. And then I put the binder on that. The other thing I do, if you can try to do it, is I actually restrain the other leg, so that moving of one leg doesn't cause motion on the other leg. The Impeller leg usually always is restrained, but motion on the other leg can sometimes cause motion on the other one. So I try not to do that now. And then we have beds that try to avoid pressure ulcers and move the patient without having to actually flip the patient, etc. Immediate Foley's, obviously, the rectal tubes go in, so we don't have to turn them for stool or incontinence, etc. But this is more finesse and the art of managing the Impeller position than anything else. We also automatically get a chest X-ray at the time they enter the unit. We also fluoro the Impeller position at the time of the insertion and right before we take them off the table, so that we compare the chest X-rays so we know exactly where the Impeller is on fluoroscopy and X-ray. And then on top of that, they all get an echo immediately after they enter the ICU to document the position of the Impeller. And then you have the numerical markers on the back of the Impeller to tell you where it is at the level of your sheath. And the final thing is I try to take the slack out of the Impeller. So how I take the slack out of the Impeller is after I insert the Impeller, do the case, whatever, I actually pull the Impeller back a little bit to straighten it and then push it back in. That removes a little bit of the slack, so there's not a lot of tension going on, so that when they go, we don't actually lose the slack on the way out, and then it gets pulled back a little bit. So these things people do. There's not really a way to tell you if all these things work. I just do all of them and hope that the Impeller doesn't move. And it has helped for us.
Thank you, Dr. Patel. That was an excellent presentation. We really appreciate you joining us.
Great. Thank you guys for the invitation. I appreciate it.
Awesome.